You will notice epistaxis. So there's that very high risk for bleeding in these clients. Another obvious symptom you want to take note of would be ascites. What's ascites again? When you have too much fluid that is building up in the abdomen. So again, you're going to see this in clients with liver cirrhosis. Also, they can present with hemorrhoids. If you look at their, okay, we already said they have this increased bleeding tendencies. They could be anemic. And again, they will have this edema in their extremities. So they're going to have edema in their extremities, and they would also present with what we refer to as spider angiomas or vascular spiders. And this is what it looks like. So these are like blood vessels with that central, you can see in the middle, there's a red spot. So you have this central red spot, and again, it has all these reddish extensions. So that's what you would also see in clients with liver cirrhosis. Again, what are those key things you need to take note of? Nclex is going to tell you a client presented with a history of alcoholism. Remember, we said cirrhosis could be caused by, probably caused by alcoholism, or they could tell you this client had a previous viral infection or viral hepatitis. So again, and then they tell you this client came in with bleeding, oesophageal varices, edematous extremities, and then the spider angiomas. You want to already start thinking of liver cirrhosis. Again, if we do an investigation, you will notice the liver would also be enlarged. He could also present with biliary disturbances. Again, when we talk about bile, what comes to your mind? I'm already thinking jaundice, that yellow skin, yellow eyes that is caused by buildup of bilirubin in the blood. So again, I'm already thinking jaundice in this client. And remember, jaundice would occur if the liver is diseased such that it can't efficiently process red blood cells as they are being broken down in the body. So this client is going to present with liver cirrhosis, going to present with jaundice, and again, you're going to have that characteristics pruritus, the itching, as a result of this buildup of these toxic metabolites in the body. What else are we going to see? Again, still related to the biliary disturbances, we are going to notice that this client is going to present with complaints of his urine being dark colored. His stools would also be clay colored. So again, that again is a pointer to what this patient might be having. Again, if we do measurement of the abdominal gate, you would notice he would have an increased abdominal gate. So those are some of the key features you want to take note of for the Nclex when you have a patient with liver cirrhosis. Okay, so again, this is like a summary of the key features. We said there will be that jaundice because the liver is failing to work as efficiently as it should. There would be encephalopathy. Again, when the metabolites are building up in the brain, it's going to present with confusion, coma, loss of where he is, place and time, all of that. We also talked about the spinal angioma. You would also see muscle wasting, lack of body hair, and then ascites we talked about that is building up in the abdomen. So those are some key features that you will see in clients with cirrhosis. Again, the Nclex is all about your index of suspicion. Are you able to identify elevated pressure within the venous portal system or the portal vein? One obvious complication that can arise would be portal hypertension. Again, remember those oesophageal varices we talked about, that possibility that these veins are running on the lower esophagus to the stomach, that they can rupture, and that could lead to hemorrhage. So again, you want to be conscious of that. Remember, the Nclex is more of a safety exam. Are you able to identify when certain conditions pose risks to your clients? So again, if I have a client with cirrhosis, I already know this client is at a very high risk for bleeding related to the portal hypertension, related to the esophageal varices. So I'm already thinking of how I can keep my patient safe. Remember, Hemorrhage is a leading cause of death in clients with liver cirrhosis. Okay, what other complication can arise? There could be peripheral edema and accumulation of fluid in the peritoneal and abdominal cavity. That's another complication that can arise. Edema and the ascites. Remember, this would also be associated with dehydration and even hypokalemia in your clients. Another severe complication that can arise would be hepatic encephalopathy. So again, we said there's going to be build-up, that toxic build-up or accumulation of toxins like ammonia and other toxic metabolites in the blood. So you're going to see changes in level of consciousness in these patients that will finally lead to hepatic encephalopathy and even coma. What are those symptoms of impending coma you're going to see in your clients? What are you supposed to look out for, or what would you see that will tell you your patient is progressing into hepatic encephalopathy? We're going to see disorientation to time, place, and person. And you're also going to notice asterixis. So what would this be again? If you ask them to extend their arms and have their hands held upward, like if you ask them to dorsiflex their hand, so you want them to stretch out their hands, extend their hands, and have them held upwards, you're going to notice some flapping tremors. So that flapping tremors is what we refer to as asterixis. So again, that's another symptom of impending coma in your client. So again, because of all this buildup of metabolites, treatments must involve removing those toxic substances, especially from the intestines. So we're going to talk about that subsequently. So what will be the last complication that can arise with liver cirrhosis? We're going to see hepatorenal syndrome. Again, on the Nclex, most times you want to break words, you want to break them down so that you can understand what that word may be, especially if you're coming across a word you are not familiar with. So now I see hepato. Hepato tells me liver. Renal tells me kidney. So I can just make it up and say, okay, it has to be something wrong that's happening with the liver and the kidney. So hepatorenal syndrome is a condition of acute kidney injury or kidney or functional renal failure that is usually seen in clients with advanced liver disease. And you're going to see signs of azotemia. Again, like I said, you want to break down these words and it will help you to understand what each of them is. So what would be azote? Azote means nitrogen. Mia means blood, in the blood. So there's excess buildup of or elevated levels of nitrogen and urea in the blood. So that tells me, again, why is this happening? Because the kidneys are not working as they should, because the livers are not working as they should. So you're going to see azotemia in this client, and we're also going to see that buildup of fluid in the abdominal cavity. So again, hepatorenal failure, hepatorenal syndrome is another complication that can arise with liver cirrhosis. So what's going to be our plan for these clients? Okay, so the first thing we want to do is to put a shunt. Remember, we talked about that portal hypotension, the increased pressure within the portal veins. We need to put a shunt that can relieve that excessive pressure. So this is what our shunt should look like. So this is what the normal orthosystemic system looks like. But again, you can see we've created a shunt here just to relieve that portal. Sorry about that. So we want to put a shunt to relieve that portal hypertension. Again, we want to provide appropriate nutrition for this client, especially in the early stages. We want to provide high protein, high carbohydrate diets, supplemented with vitamin B complex. What does the vitamin B complex help us with? It's going to help with memory. It's going to help with nerve problems. In the advanced stages, fiber, protein, fats, and even sodium restrictions, high calorie diets, protein foods of high biologic value. That's what we want to serve our clients. We want to also provide this meals in small, frequent feedings. You want to have some fluid restrictions. And again, you want to have your clients avoid alcohol. Remember, we said this client is at high risk for bleeding, so we want to monitor for bleeding. If we may, we might need to administer blood products. Again, remember with COCs, we are thinking of esophageal varices, we are thinking of hematemesis, we are thinking of epistaxis, we are thinking of hemorrhage. We also want to observe for signs of shock, especially if we say this client is at risk for bleeding. You always want to observe for signs of shock. We want to monitor our abdominal gaits. At least that will give you an idea to see if the condition is progressing or the patient is getting better. So you want to monitor abdominal gaits and carry out daily weights. You also want to maintain skin integrity. Remember, we talked about pruritus. We said the clients have this itching from the buildup of metabolites. So again, we want to maintain skin integrity, avoid strong soaps that are very strong. To avoid that, you want to apply anti-itch creams or topicals. And again, you can also carry out frequent position changes. So this would also help to maintain skin integrity. Still on that plan, we also want to assess the degree of jaundice. You want to promote rest in this client. You want to promote adequate respiratory function. Remember, with the buildup, the ascites that is building up in the abdomen, it could affect his breathing. So we want to promote adequate respiratory function. We want to reduce exposure to infection. Again, with this client, because of that safety risk, remember I told you the Nclex is more of a safety exam. Safety is always your priority. Your patient's safety is always your priority. We must protect safety in this client. Remember, he's at risk for bleeding. How can we promote his safety? We want to encourage him to use electric razors if he's shaving. You want to encourage use of a soft bristle toothbrush. Again, if we carry out venipunctures, we want to put pressure to the site because of that high risk for bleeding. We also want to reduce ascites. Remember that, we already talked about that. So you want to carry out sodium restrictions, fluid restrictions, and we might need to place him on diuretics. Again, we talked about hepatic encephalopathy. We said hepatic encephalopathy is a loss of brain function when a damaged liver is not able to remove toxins from the blood, leading to buildup of ammonia and other toxic metabolites in the blood. Again, treatment involves removing those toxic substances from the intestine using medications like lactulose. So again, when I see lactulose on the exam, I'm already thinking liver cirrhosis. Again, we can use lactulose. It helps to bind to the ammonia and it will help to excrete the ammonia from the system. Again, in patients with hepatic encephalopathy, usually we give them lactulose in syrup form 2 to 4 times a day. And what are you aiming for? You are aiming for 2 semi-soft stools per day. Again, we are aiming for 2 semi-soft stools per day. That's for clients who have hepatic encephalopathy. But if they present in an acute condition, the common option is to administer a bolus dose of lactulose, like maybe 45 mils, and we want to repeat it hourly until we have our first bowel movement. So again, lactulose for our stable client, our aim is to have 2 semi-soft stools per day, but with acute clients, we want to give a bolus of lactulose and repeat it hourly until the first bowel movement. These are key points you must note for the Nclex. Again, we can also place him on neomycin. We'll need to encourage bed rest in this client with hepatic encephalopathy. Remember, we said bleeding is a major problem. So how do we resolve these bleeding varices? We talked about those esophageal varices. So with treatment of bleeding esophageal varices, remember, esophageal varices are those abnormal veins that are running from the throat to the stomach. And we said they develop when the blood flow to the liver is blocked. And we said with these varices, there's a very high risk of bleeding. And for this, we might want to insert a balloon into the esophagus. So we're going to insert a balloon into the esophagus, and then we're going to inflate it, and this will help to alleviate or stop any bleeding. And an example of one of these types of balloon will be this, which we have on the screen. It's actually called a Nclex Blakemore tube. A Nclex Blakemore tube. So that's one example of an, it's actually called a balloon tamponade also. So it helps to put pressure on those esophageal varices to help to stop the bleeding. So again, if you look at the tube, you would notice we have, it has 3 lumens. So one, which is a gastric balloon inflation lumen. So this is our gastric balloon inflation lumen, and this would help to, if we inflate this with air up to 100 or 200 mils, that should inflate the gastric balloon and put pressure on any bleeding varices there. There's also the second lumen to inflate the esophageal balloon. So if we inflate that also, it's going to help to inflate this esophageal balloon. And then there's the gastric aspiration port, which we would need to connect to suction. So that's your gastric aspiration port there. So again, remember, there's no esophageal suction port on this, and this can cause saliva to pool in the esophagus. And it also puts this patient at risk for aspiration. So again, that's another cue there for the Nclex. What's a major risk that can happen with your Nclex Blakemore tube? We can have saliva pooling in the esophagus, and this could cause aspiration in our clients. So you need to take note of that. We also need to know that these tubings have to be irrigated hourly to prevent occlusions from these secretions. And again, if we are taking them off, we need to deflate the balloons sequentially. So again, we want to start with the esophageal balloon first before we deflate the gastric balloon. So again, when we are deflating, we want to deflate sequentially with the esophageal balloon first. Again, complications can also arise with the use of our Nclex Blakemore tube. Complications, you know, since the tube is passing through the nose, there might be necrosis of the nose, of the stomach mucosa, and the asphyxiation we talked about. Another thing we must note is that if you have your patient on this kind of tube, you want to keep a scissors at the bedside. We want to keep a scissors at the bedside. Why do we have to keep a scissors at the bedside? Remember, we need to keep observing these clients for sudden respiratory distress. What could cause this in this patient? If the gastric balloon, which is this, if this gastric balloon ruptures, then it means this tube can move upwards, and it could cause an obstruction, a high up obstruction there. So if we lose this air in the gastric balloon, it can cause this tube to move up, because if you look at it, you see the gastric balloon is what is actually holding it down there. So if we lose this, then this tube can move upwards and suffocate our patient. So that's why we want to keep monitoring for sudden respiratory distress. And if you notice any, we want to suspect, is it possible we've lost this gastric balloon? And we need that scissors at the bedside to cut this tube so that we can deflate the esophageal balloon and pull out the tube. So again, other ways we can treat our esophageal varices would include endoscopic sclerotherapy. So this would be injecting a sclerosing agent into the esophagus, and it's going to cause those varices to become fibrotic. So that's an example of, so you can see there, these are those varices. So you can see the varices, and then they are injecting those sclerotizing agents, and it's going to cause these varices to become fibrotic. So that's one way we can also deal with this esophageal varices. We can also administer vasopressin. Okay, so these are going to cause constrictions of the splenic artery, which is temporarily going to help to lower the portal pressure and also reduce the risk of bleeding. We can also carry out room temperature saline lavage. So again, remember, the saline is always going to be cooler than the body temperature. And when we do this, it's going to precipitate local vasoconstrictions in that area that would have these esophageal varices. Other methods we can use would also include esophageal banding therapy. So this is actually a modified endoscope with a rubber band that's passed into the esophagus and is used to band the varices. So you can look at it there. So that's what it actually looks like. So you can see the endoscope, the modified endoscope, and has the ligating band there. So it's passed over the varice, and then the ligating band is used to tie it off. And that's how you want to also manage this with esophageal banding therapy. Other ones we can use would be the transjugular intrahepatic post-systemic shunting, which is your TIPS. We can also carry out a surgical bypass. So that was a quick one on what we need to know for liver cirrhosis. Another topic I would like us to review would be peritonitis. Again, like I mentioned on the Nclex, you see a word out there, you don't know what it is, you want to break it down. Periton, that tells me peritoneum. Itis, what's itis? That's a suffix that denotes inflammation. So when I see itis, periton, I'm already thinking of inflammation of the lining of the peritoneum. That's the abdominal wall and coverings of the abdominal organ. That's what we refer to as peritonitis. It's often life-threatening. What are the risk factors for a client for peritonitis? So let's look at this image. What are our risk factors? So again, clients who have undergone abdominal surgery, clients with ectopic pregnancy. Again, if it ruptures, it's going to cause inflammation of the peritoneum. If you have perforations, maybe from trauma or abdominal ulcer or an appendix that ruptures, or even diverticulum, that could be, those can be a risk factor for peritonitis. Again, with our assessment, what are we going to see in this client? One obvious sign you're going to see is that abdominal pain. Most times it's even going to be severe. So you're going to see abdominal pains in this client. They're going to complain of severe abdominal pain. Again, you will notice this, what we refer to as board-like abdomen. You know what a board is? When the abdomen is as rigid as a board. So you're going to see this board-like abdomen or abdominal rigidity. Again, the abdomen is going to be distended. Or they could even have these ascites we talked about previously. So you're going to see abdominal distension or ascites in this client. One other obvious symptom you would see is what we refer to as rebound tenderness. So they use a basketball here, you know, one refer to rebound, when you have a rebound in basketball. So what happens with rebound tenderness is actually a clinical sign where press down on the stomach, the patient doesn't have that pain, but when you remove your hand, they are going to complain of severe pain. So there's going to be pain upon removal of pressure, rather than when you apply pressure to the abdomen. That's what they refer to as rebound tenderness. And you're also going to see that in your patients. They're also going to complain of fever. So you're going to see the temperature above 100 degrees Fahrenheit. You're going to see nausea and vomiting. The client is going to complain of anorexia. Okay, we already talked about the fever. Again, high fever tells me possibly there's an infection. There could be increased white blood cell counts. Even the fever could also lead to dehydration. One other obvious sign you will see with peritonitis is that the bowels will be sleeping, or what we refer to as paralytic ileus. The bowels are not, that peristalsis you should be seeing, you don't see that movement. The bowels are not active as they should be. So again, because the bowel is not working as it should be, the bowel sounds, if you listen to the bowel sounds, they'll be diminished. The patient will be unable to pass gas or even feces. So again, you will see that paralytic ileus in your clients. If we look at the blood pressure, it will be increased. The pulse would also be increased. So what will be our plan for this patient? Key things I would like us to focus on for the Nclex. We must carry out gastric decompression. So you can see how the patient has a tube going to the stomach connected to a wall suction. So we want to decompress the stomach. Remember, we talked about that they could have ascites. So we're going to help, we're going to carry out gastric decompression to help to control that abdominal distension, because that would also help to protect our client from aspiration. We're going to monitor the NG drainage from this client. Again, if you have your client in an NG tube, if you have an NG tube in place and your patient complains of nausea on the Nclex, what's the first thing that wants to come to your mind? You're already thinking an obstruction. Is that NG tube obstructed? So that's the first thing you want to do. If my client has an NG tube, or the client is out of surgery and an NG tube has been placed and he complains of nausea, I'm already thinking, is there an obstruction? Is the NG tube functioning correctly? Because usually when a client has nausea and they have an NG tube, it's almost always because of a blockage of the NG tube. Okay, so still part of our plan, we're going to keep this client nil per oral. We're going to establish fluid and electrolyte balance. We monitor the client's serum electrolytes. For the pain, we're going to manage the pain. Again, on the Nclex, pain is psychosocial. Pain is psychosocial, except it's a life-threatening pain. Pain is never going to be your priority on the Nclex if you have other physical problems to deal with. We'll talk about this during the decision tree class, but again, most times you didn't get the question wrong, you just fail to understand what the question is about. Remember, if you have a physical question, you must have a physical answer. If you have a psychosocial question, your answer must be psychosocial. Your answer must always address the topic of the question. Again, for this client, we might need to carry out parenteral nutrition. That's when we have to give him nutrition through an intravenous administration route. So maybe proteins, vitamins, electrolytes, and all of that. So again, we might need to carry out, give our client parenteral nutrition. So that's with peritonitis. Again, remember those key features. Just to wrap it up, rebound tenderness. Think about it. Whenever my client has that, I press down on the stomach, it doesn't feel the pain. I take out my hands, it feels severe pain. That's rebound tenderness. I see diminished bowel sounds. My client has fever. Again, the Nclex will tell you this patient presented with this, this, and that. You must be able to identify, add those symptoms, add 1 and 2 together, and know what condition the patient is presenting with. Most people read the Nclex and they always go with the topic that they see or a disease condition that they see. They tell you the patient came into a patient diagnosed with high blood pressure, came into the clinic, and then you just focus on the high blood pressure. No, most times the question is not always about the topic. It's not always about the disease condition in the question. You need to understand what the question is about, and that would help you to arrive at the correct answer. Let's look at pancreatitis. Again, look at that suffix there again, itis. We said itis denotes inflammation of an organ, pancreas. So this must obviously be a disease process where the pancreas is inflamed. It could be acute, it could be chronic. What are possible causes? Or if you look at the patient's history, the patient who is presenting with pancreatitis, what would you notice? One obvious history you will notice would be alcoholism. Again, how does this come about? The pancreatic cells sustain damage from all the metabolites that come from alcohol metabolism. So the person has been drinking, and as the body breaks down all of this alcohol, those free radicals and other toxic byproducts from alcohol metabolism can damage the pancreas or cause the pancreas to be inflamed. That's why we see alcoholisms related to pancreatitis. So again, you want to take note of that, because if they tell you the patient presented with a history of severe alcoholism, I'm already thinking pancreatitis. Again, there could be a history of bacterial or viral infection, or maybe a trauma to the pancreas, or even as a complication of mumps. Or even as a complication of mumps, or even medications So again, medication use have also been known to induce pancreatitis, like your thiazide diuretics, your corticosteroids, your oral contraceptives. Those have been known to induce pancreatitis also. Again, when this patient presents, what are we going to see in our patients? They always come with abdominal pain, nausea, vomiting, 24 to 48 hours after a heavy meal or alcohol ingestion. Again, as I'm reading through, making up those stories in my head, a patient presented with abdominal pain and vomiting after eating a heavy meal. I'm already thinking pancreatitis. A patient presented with abdominal pain, nausea, and vomiting after drinking all through the night. I'm already thinking pancreatitis. If you check the blood pressure, you would notice your patient will be hypotensive. Again, we could see acute renal failure in this patient because those inflammatory cells and toxins from the inflamed pancreas can cause harm to the kidneys, and you can have this sudden renal shutdown or renal failure. So again, we can also see that in our clients with pancreatitis. And then the obvious one that is always a giveaway, when I look at the flank, my patient's flank, and I see that gray-blue discoloration, what we refer to as your Turner's sign. So that's our Turner's sign there. So when you look at the flank, you're going to notice that gray-blue discoloration. That's an obvious giveaway on the Nclex. My patient obviously has pancreatitis. Where is this? Why are we having that discoloration there? Because the seepage, blood-stained exudate from the pancreas is seeping out, and that's what is causing that discoloration. So again, what's going to be our plan for this patient? We want to keep him neoperoral. We also want to carry out gastric decompression. So again, what's gastric decompression? The procedure performed to empty contents of a client's stomach quickly. So we're going to carry out gastric decompression. We'll need to place this client on medications like our antibiotics, opioids, histamine blockers, our proton pump inhibitors. So again, your proton pump inhibitors are going to help to reduce further pancreatic secretions. We need to maintain fluid and electrolyte balance in this client. We need to carry out good respiratory care for this client. We want to ensure that he coughs and deep breathes every 2 hours. Again, we want to put him in semi-Fowler's position or other position of comfort. We want to monitor for shock and hyperglycemia. Again, remember the role the pancreas plays in management or maintaining our blood sugar levels. So if there's a damage to the endocrine pancreas, we can obviously see hyperglycemia in this client. So we want to monitor for shock and also for an elevated blood sugar. We also might need to put him on parenteral nutrition, which we said is IV administration of nutrition. And again, long-term treatment involves avoidance of alcohol and caffeine, all these stimulants. He needs to avoid them. We need to place him on a low-fat, bland diet. And every time I see small, frequent meals on the Nclex, it's usually a right answer. So again, we said alcohol could be tied to pancreatitis. So long-term treatment involves avoidance of alcohol and caffeine.
Have you ever wondered about your IQ?